Welcome to the Walk in the Park podcast, the official podcast of the Lead Up Task Force of SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. In Season 1, we will be taking a look behind the curtain of the C-suite, sitting down with individual CEO, CMO, CFO, CNO, and COOs of a diverse range of physician practices and hospital systems. Please remember to hit the like button and subscribe to stay up to date on the latest episodes. Enjoy the show. For our episode today, we are thrilled to welcome Dr. Klaus Thaler, MD, Faculty of the American College of Surgeons, and MBA. Dr. Thaler is a colorectal surgeon who started his career in Vienna, serving as chief of colorectal surgery before moving to the United States to pursue surgical residency and an MBA. He has served in numerous leadership roles, including CMO at several health systems, chief quality officer, and VP of medical operations. He is a proven executive with experience attracting, recruiting, mentoring, and managing teams of up to 1,000 in organizations up to 2.5 billion. Welcome to the show, Dr. Thaler.
Thank you so much.
And thank you so much for joining us. We really appreciate it. Before we dive in, just even though that was a great introduction, tell us a little more about yourself so we have a little better understanding of your background.
So I'm an immigrant from Europe, from beautiful Vienna, Austria. And I came to the country 25 years ago. I am a surgeon by background, as was mentioned before. Over the last 25 years, I went from academia to become chair of surgery, leader of a surgical department, to finally move into the rank of a CMO, chief medical officer, almost 10 years ago. I started that with a very prestigious institution, which is Houston Methodist, and then went to work for the largest healthcare corporation in the country, which is HCA. I managed a couple markets there. And then, I ended up back in academia, but in a different role, in the CMO role, working for Creighton University and CHI here in beautiful Omaha, Nebraska. I think my unique experiences that comes with that role is also that I was always heavily involved in operations that started out with surgical operations in perioperative services, working closely with all different subspecialties of surgery together. And that also helped me to get me a better understanding what the needs of surgeons are when they are in clinical practice, being independent or employed, and how to best serve as a physician in the C-suite the surgical subspecialties, all subspecialties across the border.
That's wonderful. Thank you for sharing all of that. In your current healthcare system and role as chief medical officer, what would you summarize as kind of your main day-to-day job?
So I would say my main day-to-day job is communication and being transparent to what we do in the C-suite on a daily basis, how we support resources, what the challenges are, and to hear back from our medical staff, not only, of course, from the surgeons, but also from the surgeons, what their needs are, so that we can be more proactive and not only reactive when something goes wrong. The other one is to really continue to create trust. We cannot create more trust every day. We need to do that, and to create a collaborative approach, a multidisciplinary approach when it comes to developing new programs, when it comes to developing new service lines or growing existing programs and service lines, and do this together with our medical staff and also with the leaders of them.
Yeah, It sounds fantastic. I think we all would want to be working under you actually to get things done. And then you mentioned it, you gave a little more of your background, but really, not a lot of surgeons think about, the administrative path, the CC path as a way to impact change and to kind of go that route. So can you give us a little more kind of just behind that real motivation for you to kind of be willing to step into that world, the world that's pretty foreign to most of surgeons, right? The C-suite is an entity, if you will. And why would you want to step into that role when you spent all this time, all the clinical training and taking care of patients? Why move to the administrative side of things versus staying in the more clinically active, I guess is the way I can put it.
So when I moved up the ranks in surgery from being a division chief to a chair, I realized over the years that there is a gap between the C-suite in the systems I've worked and the surgical the clinical departments, so to speak. And my number one motivation to become a physician in the C-suite is that I think a physician executive is the connector. And he needs to be the connector to the non-clinical executives in the C-suite to understand better what the clinicians' needs are and where do we need to set priorities, but also on the other side to the other stakeholders on the clinical side to explain to them what challenges the C-suite has and what challenges the C-suite faces on the organizational side, on the payer side, on the community side, what we need to accomplish there. So I think that was my number one driver. I gave up a lot because I gave up at some point after I started this CMO role. I gave up my clinical practice years later. So it was a lot of things that I really love to do, but I felt so important that we need to have more physicians in the C-suite. And I especially feel, and you mentioned that before, that there was such a scarcity of surgeons in the C-suite historically that I felt more surgeons need to be there. And this was really my main driver. And ever since then, I have really focused on that on a day-by-day basis. I never drifted apart from that, from my number one vision that I had when I became a C-suite member.
I think your aspirations in pursuing a role in leadership are exactly what we're trying to kind of demystify for the membership. And your insights, I think, are invaluable in what we're trying to accomplish with this podcast. In this journey to your leadership role, working towards that goal of becoming the connector between the clinical care teams and the C-suite, what are some specific pearls of wisdom that you would share that were things you didn't understand when you were still in your clinical role that now seem so obvious to you?
So when I was in the clinical role, I was a steward of my department. And I requested things that I didn't understand why I got denied by senior leadership of my system and of my hospitals. Because I didn't know the organizational needs. I didn't know the bottom line. And so while I was focused on my department, I was not always entirely successful to get everything that I felt the department needed at the time, and I was frustrated. Now, moving into a C-suite role, I'm now steward of the organization. And what I try to convey to my surgeons and to my clinical departments that they need to work with me to also understand that we have a fiduciary role for our teams in the department, for our department members, for the patients that we serve every day, and but also for the organization. And we need to be stewards of both of this, and then it benefits everybody. And that was the most difficult transition I went through because I was very directional in the beginning. Yeah, I had a certain conflict to vote for surgery needs in surgery surgery resources to give surgery when I started my CMO role. But I realized over the years that you gotta communicate that we are all in this, and we are a multidisciplinary team, and it has to be an effort as such. And I think that was the one red line to follow, and that was also the most challenging one that I had to go through, and I had to overcome when I changed from a department leader to a system leader. The other one was my leadership style changed. Surgeons are usually directional leaders, more historic leadership style, more transactional. I changed that leadership style over the years, also through getting my MBA, but also through learning through in practice that I morphed into being a transformational leader to really educate and train the team how to accomplish success, and then support that and be servant, which I wasn't always as a surgical leader.
That's great. It's funny, actually. The silo, I think that the concept of the silo, we all do that, right? Like, it's
Right.
not just surgeons, though. We just seem to be the best at siloing everything and thinking that, we have our wall to wall what we're doing. So I think that's an important piece to really break down for everyone is we exist within a larger organism, despite if we want to admit it or not. So let me ask you this, though, and taking a little different spin, because SAGES is an international organization. We have members who've experienced different types of health delivery systems. A large majority of us are United States, and I've only known the United States health system for good or for bad, or for better or for worse, if you will. You have that rare position of having seen more than one system and worked in more than one system on the international side and the United States side. So from your perspective, navigating the United States health system, which we know is an ever-changing beast of a landscape and has its challenges. What does it stand out most to you when you transitioned over to the United States side, finding to navigate, especially now with your C-suite hat on, navigating that system and allowing for better access to care and better quality care to be delivered?
So when I transitioned over from Europe, from a social medicine based healthcare system or systems to the US, we had a different situation in the US, right? The horizon was still bright there, and the sun would shine every day, and we still get it. We got the fee for service that we charged the insurances for, and especially the government insurance, CMS. And that has dramatically changed since I've been here in the country over the last 25 years. I would say especially over the last 15 years. And I think we are coming closer between having a 100% social medicine-based healthcare systems in Europe 25 years ago to where we are now in Europe and where we are now in the US. So in Europe, they also have, I would say, about 30 to 40% of patients in Middle Europe, at least, in Germany, Switzerland, Austria, they have also commercial payers insurance and not only state insurance or government insurance there, which has changed dramatically. And on the US side, we are going more and more into a shift from government insurance to managed Medicare, as an example. And if you listen to the advisory board or to advocacy makers here in the country, that will become even more and more over the next 10 years. So I think we're finding each other more closer in the middle of the bell curve in Europe and here, especially Middle Europe and the US. The other important driver here in the US is value-based care. And we have talked about this over the last 15 years, and I think we are coming closer and closer now, regardless of the leadership we have in the country. We're coming closer and closer to really enact on government on value-based care, which is driven by this, has to be driven by the state and by the government. and there's no way out to that, which also impacts us significantly. And Europe had always an advantage being in social medicine, but coming not close to the middle here, where they had much more control over spend, right? Pharmaceutical spend, for example. Yeah, I mean, we are paying for a cancer drug here a multiple still what we can charge, or what your healthcare systems, what the pharmaceutical industry can charge healthcare systems in Europe. And I think, the direction is a good one. The healthcare systems in both continents, and also especially in the US, need to learn how to optimize care better, so that they have less spent, and they will be the care that we provide here more valuable, and the equation quality over cost, yeah, will go to the quality side, and will also reduce the costs there. I have to also add that this is something we need to continue or start to educate our learners. I realize, working again in the academic system in my CMO role now, that the learners do not study that in medical school, and really not in residency. So I'm also a adjunct professor for Creighton right now, and I teach there. And I focus now there not only on leadership in medicine and surgery, but also on understanding the healthcare system better, and how, as a provider, either academic, non-academic, I can contribute to that.
Some of our listeners know my background as a big person about healthcare advocacy and policy. They're only going to hear this, not see. They would see the big smile on my face right now because I'm nodding my head along. So, what you've said have warmed my heart, obviously, but that's a whole nother conversation for another time. But I appreciate all those comments.
I would have to reinforce the accuracy of your impression that it's not something that we spend much time learning about in medical training or in residency. And quite frankly, we have pretty limited exposure to individuals that are any higher up in the system than our chair of our department. So I do think that this is, a good kind of peek behind the curtain is the idea behind the podcast. And having been in this role in multiple different facets for many years, the fact that still seems to be an issue for you, maybe we can help direct our trainees and younger surgeons towards resources to help kind of make things a little less muddy for them. In terms of the individual average surgeon who you are maybe interfacing with, or who is thinking about approaching their CMO, what are specific things that you wish that those individuals knew about your limitations in your role as CMO, and CMOs in general, about how you can respond to their needs and their requests when they approach you?
I think to understand the organizational structure better, and this is my role to communicate that to the surgeons, or the individuals, to the clinicians, to understand the strategy that my organization develops every year, and the strategies in different areas that are not only clinical areas, to understand the finances, to understand the cost spent, to understand the overarching plan that the organization has. And it's getting more complex when you work for a large organization versus when you work for a smaller healthcare system. Then it's much simpler because you have less layers there. I think when surgeons understand that better, they can also better comply, and they can work closer with us together. And it's really on me and the C-suite to start that conversation.
I think that's great, and that's helpful for everyone to understand. I think again, there's that concern of there like it's some magic to go and talk to your C-suite, and we're trying to help tell people that no, there's actually a lot of goal alignment. So, but let's flip it to the other side, because we know while we've talked some of the big areas, in your role overseeing kind of all clinical activities, we know I know no one will ever admit to it, there are those quote unquote problem surgeons or physicians where maybe they're having interaction issues or clinical issues. So in your role, because you end up dealing with them in all those situations, what tactics do you use to really deal with those individuals and try to turn that into a more positive interaction, a positive relationship, turning those conflicts towards good and kind of turning things around? Like, what are some tips and advice you use? Because we all run into those conflicts, right? You probably see a lot more than the rest of us, though, because they all end up being filtered to you. So, in your experience, how are you able to turn that around? And we know not every situation can be done, but many can be. And so, what is some advice you have to kind of do that? Because we will have to deal with that in our day-to-day interactions as well, to prevent it having to get to your desk.
So uh, to have as an example, I give you an example. To have structured programmatic growth meetings with the key services we want to focus on, and include not only the physician champion, but also representatives of their departments in these growth meetings with my market team and with other stakeholders that are non-clinical. I can give you an example. When you want to grow cardiovascular surgery, we have a programmatic meeting where we have a cadence to introduce the clinicians to the non-clinical stakeholders, such as marketing, business development, clinical administrators, to work on a plan together and to start the plan with the providers involved, not to hand them, a fabricated plan after we complete the plan without their input, to start with them and making them part of the team from the beginning, and do this in a very structured way. And that accomplishes a few things. One, they get used to an administrative structure, to develop clinical goals together and financial goals together, but also that they are integrated, and it's a learning achievement for both of us on their side and on our side, on the leadership side. To also structure these meetings not only on the business side but also on the quality side. We have, as example, we all, wherever in systems I worked in the last 10 years, we always had structured meetings for quality improvement and for creating a high reliability safety culture, which is another important area, and make our clinicians understand root cause analysis, failure mode analysis, and have them actively participate. Now, with this being said, we are including our learners there too. So we have a huge initiative right now with Creighton and with ACGME, that we get the learners to the bedside and into these committees and into these work group meetings where they already understand what they feel the knowledge gap that they had in med school. And they had until now in their residency programs that they go out when they graduate and have a totally different understanding how a healthcare system works. No, this is easier said than done, right? So we are. I would say we are still at the infancies here, but we get better every month and every year here, and because we haven't lost focus, and it is really a key important part of what we do. But again, there's still a lot of opportunities out there. And I always feel, we are only at the beginning, but then looking back over the years, we have already accomplished a lot, but we still are learners, everybody, each of us.
I think that's amazing and very commendable that your institution is doing that with the residents. I think it's going to be an incredibly valuable experience for them to have had. As a little follow-up to that, I'm just curious, is that something that you implemented when you arrived at Creighton?
So I've done this in the past with the GME programs I had over the last 10 years. And before that, we started this actually with in the Department of Surgery when I was chair in New England. But it was just for the department. But now really together with the medical school here and ACGME, we have really intensified this over the last few years here. And it's hard work because you first need to create the interest, you need to share interests here, and you need to close the knowledge gaps, why we should do that. And then you need to create a total different culture between the other clinicians in this multidisciplinary team, the nurses at the bedside, the ancillary staff on the bedside, and then our learners together with our faculty, that we now are a multidisciplinary team working together in this. And this alone, the awareness here alone to create the awareness here requires many conversations and communication. I would say, 30 to 40% of my daytime, I communicate.
Yeah. Again, I think it's an awesome initiative, and commend you for that effort, and that it's been something longitudinal that you've implemented based on kind of the challenges that you've seen as a clinician who's gone into this leadership role. For the average SAGES member surgeon who is essentially fully occupied with their clinical practice, hasn't had this wonderful primer during training of how to interact with these committees, and has had no previous experience engaging with their CMO or their C-suite, how would you recommend that they approach anyone from their C-suite, particularly the CMO, to affect change based on what they're seeing in their day-to-day clinical practice?
So what I would say, they should stand up and speak up, and they should take the step to knock on the door of the C-suite, and don't be afraid of that, and don't be scared. The first conversation maybe just to connect the dots there, and but I think a modern C-suite team should listen and hear the clinicians. And I think once you break down the wall and you break down the silo, you have some understanding what the C-suite can do for you, then everything will be easier. Now, with this being said, as a leader, need also not just talk the talk, but walk the talk and go into the trenches and be visible there. So I participate, for example, in every perioperative executive meeting. Yeah, we have a perioperative executive meeting where the surgeons and anesthesiologists meet with the perioperative service nursing team, and I'll be part there and attend these meetings as much as I can. That they see actually, I take the first step here. Now it's easier for them to come and knock on my door. And I think it's really incredibly important to have an open door policy. And that was the first thing. So when I started my CMO jobs over the years, the first thing when I introduced myself at the MEC, the Medical Executive Committee, and the departments, I told everybody, here's my cell phone number. I have an open door policy. Just come to me. And I think then it's much easier for the clinicians that have a very hard working day every day to say, okay, it's worth for me to knock on this door.
I think that's a great way to approach it. To follow up, so surgeons are result-oriented creatures, right? And patience is probably not our greatest virtue at times. So we want to address something, we like to try to get it done and move on. So as a follow-up advice, so we broke it down the silos, we're having the conversations. There's going to be inevitable roadblocks or hiccups. Nothing ever goes to plan. We know that. We're designed to understand that. But what advice would you give those surgeons in those situations? Because it's very easy to get frustrated. I mean, our healthcare system is designed to frustrate us sometimes, and it's very easy to fall into that trap. What guidance would you give from your view for these surgeons on how to not get frustrated, but turn that around and try to take advantage of the situation, or at least navigate it better?
So I would say when you get frustrated, don't hesitate and come back to me and remind me that we had that conversation in the past, and ask me where we stand with this request or this resource that I promised to help them with or help you with. But in order to do that, you need to create trust first, and that creation of trust is on my side. So I have to do a lot of work in the beginning to have that trust that somebody can actually take that second step and follow up with me, because I'm not perfect. I forget closing the loop, which is a key step to close the loop. But I cannot do it all the time. So have you come to me and say, hey, just remind me. Don't hesitate. Yeah, it's fine. Yeah, you remind me. I'm always available for everybody, and they can approach me in the doctor's lounge. They can approach me in the hallway, and we have many hallway conversations when they come back. I think the other one is, as a physician leader, you can stimulate that. Yeah. So when you see them in the hallway in the doctor's lounge, hey, what's going on? Yeah, everything going well? Yeah. Do you have any more questions about what we discussed last time? If you do this repeatedly, then I think the busy clinician, will take that step, yeah, before he or she gets frustrated.
This is really wonderful advice, and it's been lovely chatting with you. Do you have any final thoughts that you think would be beneficial to share with our SAGES members?
So I think surgeons are unique in their personality, because they're very technically oriented, they are very focused, and they are very efficient what they do by every day. I think they need to know, me, myself, and every other C-suite member in any healthcare system should communicate to them that we need them, we need you in training and also after training, yeah, to help us making our system better and making healthcare better. And to really capitalize on the special skills that surgeons have in that effort, because surgeons want to be always most efficient in everything what they do, and we need to understand that. But we need to show them that they are very valuable to us, and they should not be afraid to come to senior leadership, and when they start a new role or when they're in their role, to say, hey, I have an idea, yeah, can I run this idea by you, yeah, and can we create a plan, yeah, if you like it, and if you don't like it, what else can we do? So to be active and spend not too much time out of their busy clinic time, but spend maybe a few minutes a day if they have a new idea, or if they want to run something by senior leadership, and just approach the senior clinical officer, medical officer, and take 5 minutes out of that time as a surgeon and approach them.
Thank you so much again for joining us on our Walk in the Park podcast, and for sharing so many pearls of your wisdom on this journey from clinical to C-suite. We truly believe that the SAGES members and the broader surgical community will benefit from the insights that you're sharing. And we really, thank you so much for your time, and appreciate you joining us.
Well, I appreciate you invited me and having me. So thank you. This was very valuable to me. I think back to my surgical roots here, and how much I loved it, and I love it in my role now because I can contribute to that, and hopefully will continue doing more in the future. So thank you so much for that invitation.
Thank you.
It's really been our pleasure.
And that concludes today's Walk in the Park episode. We hope that today's discussion provides you with both resources and motivation as you lead up in your practices and organizations. Follow us on X, Instagram, or your favorite social media platform @SAGES_updates. Tune in again next time and reach out with any thoughts on how to improve the podcast. We are open to suggestions. See you next time.
That's some.
Well, I keep on getting asked, have I watched the Goldbergs? And I said no, because I lived it.
That's good. I like it.
It's true and it's sad.